All right, we'll go ahead and get started. Thank you for the introduction, Anne. Oops. Wait 1 second. Pick up bar. There we go. All right, we're all good. All right. So just to kind of go through the outline, and thank you so much for joining us this evening. Just go through what we're going to talk about this evening. So we'll first go through an overview of Down syndrome and autism. We'll kind of review the criteria of autism spectrum disorder and how it might apply to individuals with Down syndrome. Talk a little bit about sort of the journey to the diagnosis of autism spectrum disorder. And then we'll give a brief sort of little snippet on sort of how we think about treatment of behavioral concerns in individuals with Down syndrome and autism. Okay.
So I'll jump in here. Hi, my name is Yamini. I'm a developmental behavioral pediatrician. And full disclosure, I'm also a parent of a child with Down syndrome, although she does not have autism. Down syndrome, as you know, is very common, about 1 in 700 pregnancies. And autism is also very common, maybe about 1 in 44 children in the US, according to the recent CDC data. And how common is it to have both? It's possible that up to 16 to 18% of people with Down syndrome also have autism. This has really come into the limelight more recently. And I still hear in the general population that people are not aware that people with Down syndrome can have autism. So this has become one of the important things that the National Down Syndrome groups have been working on to try to get the word out. So to think about autism symptoms as they apply to Down syndrome, we generally understand autism as having 2 major areas where people have differences. The first is differences in how they use social communication strategies. The criteria being differences in how you approach and respond to others. Differences in understanding and using nonverbal communication methods, such as eye contact and gesturing. Differences in interacting with other people and how you're able to make friendships for your developmental level. And all of these symptoms can, in general, be seen with people who have language disorders and intellectual disabilities, which is what can make this very confusing in different genetic syndromes, just like Down syndrome. And it's very important that you consider how these look differently for people who have both. Repetitive behaviors are also common in Down syndrome, such as patterns of movement that in the medical community we call stereotypies, things like rocking, hand flapping, jumping, toe walking, grinding teeth is also a common behavior that people with Down syndrome and people with Down syndrome and autism may engage in. Needing a specific routine, having thinking patterns that are less flexible, and having trouble shifting thought patterns is also very common in people with intellectual disabilities. Having very focused interest or affinities can be particularly more unique for people with autism and Down syndrome and uniquely focused. And sensory processing differences are seen in a lot of people with Down syndrome, but are uniquely extremely problematic for people with Down syndrome and autism. So what we've seen over time is that although it's possible to have all these symptoms without autism, people with Down syndrome and autism, generally these symptoms are a lot more pronounced and a lot more impairing. Many people with Down syndrome, as we know, can be very social, even if they do have limited spoken language and more impactful intellectual disabilities. However, if you have both, it's thought, or we've seen that people generally have much worse or much more difficult time using the social skills than you would expect for another person with Down syndrome at a similar intellectual communication level. Go to the next slide. The other thing that we think about when we diagnose autism in people with Down syndrome is, what are the implications of a diagnosis? This is somewhat controversial in the field in that we know that people with Down syndrome without autism would also benefit from access to ABA, but people who have both definitely should qualify and do qualify in Massachusetts. There's a newer legislation that has not yet been passed, but continues to come up as to whether people with Down syndrome without autism could have access to ABA. And we do know that in early ABA literature, people with Down syndrome were seen to benefit. It also raises a question about if you have both diagnoses, does this affect placement and educational options? Certainly, we've seen people be maybe pigeonholed if they have the autism diagnosis and Down syndrome. And there may be additional stigma for some, making them not want to pursue the diagnosis. And I think we're all worried about housing for all of our loved ones. And certainly would housing be even more limited if you have both diagnoses? Next slide.
All right, so I will take it from here and talk a little bit about treatment and psychopharmacologies. As we've talked about before, ABA is typically the mainstay non-drug treatment for behavior challenges in autism and people with Down syndrome. At this time, unfortunately, despite lots of research and effort, we don't really have any medications that affect the core symptoms of autism spectrum disorder. And so what we often are looking for is kind of what target symptoms or what associated challenges does the individual have that we can potentially make better or help with medication or therapy, including aggression, irritability, anxiety, and hyperactivity. As of this point, in terms of what medications are even approved in autism spectrum disorder, well, we definitely use a host of medications and a variety of medications in individuals with autism spectrum disorder and Down syndrome. Risperidone and aripiprazole, at this point, are the only two FDA-approved medications that have an actual indication for irritability in individuals with autism spectrum disorder. So I always like to think about what do you want to consider when deciding whether to start medication. So the first thing we think about is have things improve with non-drug treatment. So things like doing ABA or having things placed at school, depending on the level of the individual's language, you might think about more like a cognitive behavioral therapy. So just different mechanisms and methods of treatment, trying those options first. What is the impact of the symptoms on school and at work? And this is one where I do see it's pretty impactful, particularly in my patients with Down syndrome. I would say that, for the most part, a lot of the individuals that I work with Down syndrome are incredibly social and really enjoy being with other people as well as being with typical peers. And that seems a bit in contrast to individuals with sort of autism and not Down syndrome. And so I find that when there's a lot of behavioral challenges or symptoms, that can sort of limit the child's environment in terms of where they might be able to get their education or what social activities they're able to participate in. So I like to think about that as well in terms of how could treatment potentially allow the individual to be more inclusive and allow them to kind of enjoy life to the fullest and participate in other activities. The other thing that I like to think about is the family and how much stress does the symptoms of where the challenges place on the family. I find that a lot of my families are wonderful and try to, really limit the child's distress by sort of changing the environment or adapting the environment. And over time, that can really cause limitations in terms of activities that the family might want to do together, social opportunities. It can really lead to some isolation and stress. And so thinking about treatment can also not only help the individuals in terms of quality of life, but also the whole family as a unit. The other thing I like to think about is how difficult is it just to go out and do things? Are they able to easily leave the house? Is the individual able to participate in things? So thinking again about sort of how much are the symptoms of kind of keeping the individual home. So just the main thing that I probably see the most in terms of autism spectrum disorder and individuals with Down syndrome in sort of as my role as a psychiatrist is irritability and aggression. As of this point, as talked about before, we have we call our second generation antipsychotics. We wish they would change the name because we don't really use it for psychosis. The individual is not psychotic, and the other name is neuroleptic, but I don't think that's any better. But just my personal preference there. So side effects include increased appetite, weight gain, drowsiness, abnormal movements, and metabolic syndrome, which is weight gain, high blood pressure, cholesterol, and a bunch of different abnormalities there. The one thing I do find unique about the individuals that I treat with Down syndrome is that there seems to be a dose that can be lower, that kids with Down syndrome respond lower to lower doses than I would expect, which is great because the symptoms in terms of those side effects are related to sort of how high the dose is. And so it's always nice when we can kind of use the, we call the least of, the minimally effective dose in terms of treatment. Weight gain is a significant concern as many people with Down syndrome do struggle with obesity. And so over time, it's just something that needs to be closely followed. But there are things that we can do to help mitigate that, whether it's medications, whether it's lifestyle changes. And so while a significant concern, it is something that we are able to kind of think about and think about how we can manage it. Uh-oh. Sorry about that. I'm not done. Hold on. I'm a little technically challenged sometimes. Sorry about that one. All right. And so we do like to kind of talk about a little bit about sort of what the research might show in individuals with autism spectrum disorder and Down syndrome. Overall, I think over time, this field is starting to grow. I think there's a lot of younger people who are now more interested in a specific area. And so I think that has sort of helped kind of ignite sort of a new interest in sort of research in these specific areas. But so the one study we have in terms of medication for the treatment of Down syndrome, autism spectrum disorder, and say behavioral symptoms or challenges, is what they call an open label study. So essentially what that means is that everyone knows what the patient, the subject is on in terms of medication. So everyone is offered treatment. In this specific treatment study, they had 23 subjects and they were sort of age range of 3 to 13, which is pretty wide. And looking at the symptoms, again, thinking about that target symptom approach, disturbed sleep, self-injurious behavior, disruptiveness, stereotypies, inattention, and sort of social withdrawal. SIB is self-injurious behavior for your reference. The dosing really did range from 0.25 to 1.5, and that's actually quite a low dose, considering sort of what the dosing range may be for a medication like risperidone. Improvement was seen in irritability, hyperactivity, the stereotypies, the kind of the social withdrawal, and then the inappropriate speech, which is like odd type of language. That's always one that I'm like a bit challenging to explain. They did see that there was a decrease in sleep problems, which is great. That is also a common struggle that people with Down syndrome may have in terms of difficulties with sleep. There was side effects, including that sort of increased appetite, as well as weight gain of an average of 2 to 15 pounds. And then one subject did report sort of excessive daytime sedation. And there was what we say EPS or extrapyramidal symptoms, which are abnormal movements, which can occur. And again, if they do happen, that's when, we think about, do we try something else? Or if it's, something that's really, really worked, how can we help with that? Or kind of what else can we do? And then the other one is aripiprazole for behavioral symptoms. Again, the other FDA-approved medication. And in this case, they followed a 6-year-old boy with Down syndrome and autism spectrum disorder. And the behaviors there that they were looking at were hyperactivity, provoked aggression, and self-injurious behavior, which in this individual was hand biting. The aripiprazole had gone up to 5 milligrams. Again, when I think about sort of doses I may use for other patient populations, it is quite low. And they did see improved irritability, hyperactivity, self-injurious behavior after about 8 weeks, which is pretty good. And then the side effects were sedation and not as much weight gain. Although at this point, I think the verdict's still out if it would have been the same had they continued longer, had there been more other individuals sort of within this specific study. And then speaking of research, just to give a little plug, if anyone knows any adults with Down syndrome that might have symptoms of depression, we are doing an open label, as I talked about. We know what the child or the adult, so the adult, what the adult is on, and looking at the safety of a medication called fluoxetine, which is Prozac, in the treatment of depression in adults with Down syndrome. Our contact number is there, and so if you have any interest or know anyone who does, please pass this along. And I think that's it. Happy to take questions and sort of open it up for discussion in terms of having a conversation. I'm gonna stop my sharing.
Anyone has any questions, feel free to type it in the chat or unmute yourself. I think while we're waiting for people to do that, Michelle, I wonder if you might comment on, one of the reasons you would start a medicine for someone is for safety reasons. What are the most common safety issues you see for your patients with Down syndrome and autism?
Yeah, so the most common safety issue I would have to say is actually elopement or bolting. And that sort of goes into the sort of more hyperactivity domain. And so that we might treat a little bit different and sort of think about, so we might treat hyperactivity in individuals with autism spectrum disorder and Down syndrome.
Agreed. That's a big issue in those without Down syndrome who have autism as well. Just safety, parents needing to be vigilant about where they go. Looks like we have three questions in the chat from Lisa Sanchez. The first is a tough question. How effective are medications for autism and intellectual disability without Down syndrome? What are your thoughts there, Michelle?
That's a good question. I have to say I don't have an exact number. It sometimes takes some time to find the right combination of medications.
If the question is about the autism specifically or the intellectual disability specifically, I think we know there's no medications for those indications, but.
Right.
Oh, I guess I can talk. Is that okay? Yes, okay. Sorry, I thought I put my video on, but yeah, I was just wondering if this kind of applies the same, if it's not officially Down syndrome, but you have an intellectual disability, is this kind of can this apply the same to that, or is it just specific to Down syndrome?
Yeah, so we do use for irritability and aggression, aripiprazole and risperidone are two mainstays in terms of medication treatment for symptoms of irritability in autism as well. It's pretty much the same in terms of treatment.
Okay.
And the different types of medicines that are out there that we use in autism are also used in people with Down syndrome, with or without autism. But the main issue is that there are unique health concerns for people with Down syndrome because it is a known genetic condition versus autism, which is more broad, and we may not know the genetic or what the cause is for who don't have Down syndrome. And I think, Michelle, correct me if I'm wrong, often people with Down syndrome need even lower doses or unique ways of dosing things due to their unique makeup.
Yeah, I would say lower doses. I don't know, the dosing schedule in terms of like once a day, twice a day, that tends to be pretty much the same. But it is the sort of the lower, it seems like the lower doses seem to work pretty well. So we end up stopping in terms of this is where we think we're going in terms of a dose of medication. And then we end up, kind of going much lower because we don't need to go any higher. If things are better, there's really no need to kind of keep continuing to increase the medication.
Let's answer Ms. Sanchez's second and third question, and then looks like we have another question in the chat. So what medicines are we using to prevent obesity, secondary to the atypical antipsychotics? And she's wondering over what time period you might notice weight gain.
Oh, for the one study, I mean, it was 0 to 13 weeks. I think the weight gain I see, it really depends on the child. I see some and adult. I see some individuals who will it'll be pretty rapid in terms of the weight gain, and then I have other kids that it'll kind of slowly creep up. And so it's always important to make sure that we're all kind of keeping an eye on the weight gain. So it really is individual. I think it also depends on what the eating habits were before the medication was started, in terms of if the diet was already not so great, and there was already some issues with obesity, then those are the kids that I'm a little more concerned about in terms of weight gain, and do want to really follow that weight closely. The two meds we tend to use, the mainstay right now is metformin, which is a diabetes medication that we use we'd say is off-label for individuals with autism spectrum disorder to mitigate the weight gain from the antipsychotic. We're not, in terms of sort of how it actually works, in terms of why it decreases appetite, we're not quite sure, but it is fairly commonly used now in terms of kind of weight loss, in terms of if people do need sort of medications for weight loss. And so it seems to, it's pretty well tolerated. There's no behavioral side effects, which is a nice thing about it as well. I'm not worried about it, causing irritability or sort of leading to anything else. The other one, which is kind of more of a second choice, is topiramate. Or Topamax. And so it's a medication used to treat seizure disorder and migraines typically. That one can have a little more side effects in terms of sedation, but is also effective if for some reason the metformin is just not working.
Yeah.
Too.
I think from our perspective at Lurie Center, this is an area that really needs a lot more research, just how to help people with intellectual disabilities, autism, Down syndrome, manage their weight and manage their eating behaviors. It's very difficult. And then on top of it, giving medicines that we know cause weight gain. It's very challenging for families and their loved ones. Mm-hmm. So the next question is from Ms. Ehlinger. How do you balance the necessity for medication with treating the individual holistically? Do you find that for some, medication should simply be seen as a last case resort? And of course, there's, as she notes, people who do require medications. That's a great question. I think this is where teamwork makes the dream work, right? We have to work collaboratively with parents, with schools, with ABA providers, with the adults. You're working with the other people on the team to see what's going on that's contributing to the behaviors, do FBAs, diet, exercise, time outside, good sleep, good nutrition. I think we're all hopeful for these natural strategies to work. What are your thoughts there, Michelle?
The same thing in terms of, looking at sort of, the medications are often or always should be part of a comprehensive plan in terms of ABA or whatever other behavioral services, coordinating with school. And again, thinking about diet, exercise, good sleep. So it kind of all fits in together. A medication sort of alone, can be somewhat helpful. It really is, you're not getting the full effect unless you really are thinking about sort of what else can we be doing for the individual that doesn't involve medication.
Right. Medicines don't teach skills. Often they can be helpful so that you can be more available for learning, and certainly to prevent serious safety issues that are occurring that behavioral strategies alone have been ineffective for. Another question is how to refer people to the Lurie Center who have autism. Angie, do you want to take that question?
Yes, I'm trying to type in the chat and the website went down. I'm gonna put the number in the chat that you can call. We have a central line, an MGA central line that you can call to get information about being seen at the Lurie Center. We do not at this time require a physician referral. I do have to warn people, we are scheduling many, many months out. But I'll add the phone number to the chat.
Great. Do we have any other questions from our audience?
Hi, yes, I have a question. If I was actually typing it in. My question was in terms of Down syndrome and autism. Would you, or would it be, I don't know, scientifically considered the intellectual impact of Down syndrome, which can be kind of variable? Would that put these individuals in the risk of autism, or is it something that almost unknown? Is it like maybe something linked to the genetics of, the chromosome number 21? I don't know. Which way is it? Is it really clear to scientific community that is it because of the intellectual impact we see more, we can see autistic behaviors, or is it because there's this genetic things that are happening and might actually cause also autism? I know they're not as common. It's 16 to 18%, if I saw it right. But that was a question I would like to ask, if there is any answer.
I don't believe we know the answer to that question. I have seen research where they found that families who had children with Down syndrome and autism, there was family history of autism. However, autism genetics itself is unknown. So I think that's not yet really an answerable question to a degree. And your observation is, point is a good one, that if you have more intellectual impairment in Down syndrome, it's thought that you are more likely to be at risk for autism. And what does that mean? There's a lot of interest in research, but we don't have answers yet. Good questions. Someone, Ms. Sanchez asks, how effective are meds? Do most kids respond at the right dose? And are there some contraindications to the medications? Do you want to answer that one, Michelle?
Yeah, it's referring to kids with Down syndrome and autism, or looking more at the sort of autism spectrum disorder alone?
With both autism and until, I guess I'll just call it intellectual disability if you think it applies.
Okay, but not also with Down syndrome, or yes, with Down syndrome?
With autism, not exactly, not Down syndrome, but autism and intellectual disability.
Okay. Yeah, I think most kids do respond. It just takes some time to find the right combo. It's really, in terms of like an exact number, I would say at this point, it's all very variable in terms of what medication and sort of how much research has been done. So I would say most people respond in a sense that it's worth trying if that is what is needed.
Mm-hmm.
It just can really take some time to find the right medication at times. And there's not really any major contraindications to sort of meds in general in terms of psychiatric medication, or it might be more individualized in terms of, is there with someone with Down syndrome with like the congenital heart defect. So for most of those congenital heart defects, when I speak with the cardiologist about, hey, what do you think about this? They're like completely fine with it. And so it is things that we think about in terms of absolute contraindications are not always contraindications.
Okay,
yeah.
thank you.
I wish we had those numbers to say, 80% respond.
But it's helpful to know that even in your own experience, most kids respond, so that's good.
Well, if we're really done with our questions, we'll let everyone have a few minutes back to their evening. So thank you, Dr. Howe and Dr. Palumbo, We will send the slides, and as I said, we'll post it. It usually takes about a week or so for us to put this online. So thank you for joining us tonight.